So I have nothing to disclose, and we're going to talk today about anatomy and hemodynamics of the abdominal aorta. I'm going to describe some ultrasound pathologies that we see in abdominal aorta, including AAA, and we'll review some options for AAA repair, as well as describe protocols and evaluation of aorta after endovascular stent graft repair and surveillance. And we'll review also diagnosis and management of complications of EVAR. So aorta is an elastic structure that has a slightly different waveforms in its proximal aorta, where it's a more low resistance waveforms and more high resistance waveforms you can see in more distal aorta, just because it supplies the lower extremities. And when we evaluate an aorta, we wanted to first observe it on a grayscale imaging. We wanted to look for any atherosclerotic plaque, dissection flaps, ulcerations, occlusions, luminal narrowing. We wanted to measure our aorta in its longitudinal as well as in transverse view and look at the proximal, mid, and distal portions of the aorta. And we use our outer to outer wall measurements. So there are multiple pathologies, and we're going to discuss most common ones, and one of which, or most dangerous ones. Aortic dissection is one of those that is due to separation of intimal and medial layers of the aortic wall, and usually it's an extent of thoracic dissection, or could be association, there is an association with aneurysms and penetrating ulcers, which are origins sometimes for the dissections. Causes atherosclerosis, hypertension, collagen vascular disease, cocaine in New Haven especially, pregnancy, trauma, pre-existing conditions. And it requires urgent care. That's why we wanted to be able to diagnose this even when the physicians don't suspect it. On the grayscale, what we're looking for is the dissection flap and its echogenic line. And on real-time imaging, you could see the dissection flap that separates the lumen into the true lumen, which is usually a small in diameter, and a false lumen that is usually bigger in diameter, and also if it's patent, it may show you the slow flow within. So you're going to know exactly what's going on. And in some cases, you can actually see entry point of the dissection. With the color Doppler, what we're looking for is a patency of the false lumen as well as patency of the branch vessels. In the false lumen, you can see either to and fro flow, sort of in the diastole, there is a reversal of flow you may find. And with spectral Doppler, we wanted to see if there is any possibility of stenosis of the true lumen, and also you wanted to look what kind of waveforms are there. In some cases, the dissection flaps will extend into the branch vessels, so it's very important to evaluate those vessels as well. And in this case, we have a dissection flap in the proximal abdominal aorta, and best seen on color Doppler imaging and transverse view when part of the false lumen is actually occluded. And when we looked at the kidneys, the right kidney showed no perfusion for the exception of a tiny little vessel that was actually supplied by the cortical vessel. And then on the left side, power Doppler showed good perfusion of the left kidney, so it's really important to look for these things. And the CTA just confirmed the findings that were seen on ultrasound. Aorta-iliac occlusive arterial disease is most commonly associated with atherosclerosis, and it's a chronic progressive disease that leads to complete or near complete occlusion of the aorta. And patients in these severe situations, they present with lower extremity pain at rest, claudication, abdominal pain, impotence, and if it's a full occlusion, usually the distal abdominal aorta will clot until the level of the renal arteries, and SMA will become a collateral sort of pathway to supply lower extremities. Again, we have to evaluate for organ perfusion when this kind of things happen. So on this examination, we look at the aorta on a grayscale, and we see this large calcified as well as mostly a soft tissue plaque that causes luminal narrowing, and on color Doppler seen as a aliasing within the vessel. And distally, in the right SFA as well as left SFA, we see a tarsus parvus waveforms representative of a significant stenosis above. In this sort of not a happy patient. It was an 81 years old female who came with oliguria and groin pain, and she had some right thigh numbness. And when we evaluated her aorta, we saw that mid and distal portions of the aorta are completely occluded, and the only flow we could see is in the proximal aorta. And we put the spectral Doppler, and we saw very low amplitude waveforms, and this waveform sort of not really normal just because they hit the obstructive portion. And the only vessel that was helping this patient to preserve the organs and lower extremities was the SMA. And you could see it on the CTA that was done 2 months before. The perfusion and the pacification of the aorta is normal. There is lots of atherosclerotic disease, but 2 months later, she really occluded the entire mid portion and distal portion of the aorta with SMA serving as a collateral. So these things can happen really quickly, so it's important to know that the patient has a significant PID. Like this one had stent already in a celiac artery and was treated previously, so this has to be very quickly, urgently managed. Other things that we can see sometimes in the aorta is findings of Takayama arteritis. It's an idiopathic or pulseless disease, and it's due to granulomatous vasculitis of the large vessels, affects aorta, subclavian arteries, carotids. There is a strong female predominance. Sometimes we see a higher prevalence in Asian population, and patients present with thrombosis, stenosis, or pseudoaneurysm formation within the vessels. There is a variable presentation depending on what the territorial vessels affected. So in this patient on grayscale, you could see that there is a narrowing of the lumen of the distal abdominal aorta and thickening of the wall, and that's a characteristic finding, the thickening of the wall. And she's 27 years old, young female, and her carotid Doppler was performed early on and also showed that in a common carotid artery, there is a long segment of stenosis with marked thickening of the wall and elevated peak systolic velocities that are consistent with stenosis. More distally, the common carotid artery was normal and normal lumen and normal wall thickening, or no wall thickening. Other things that we are always concerned about is AAAs, and it's a very common pathology that is seen in up to 2.5 million of people in the United States. There are multiple risk factors such as male and gender, advanced age over 65 years old, history of smoking, family history of collagen vascular diseases, atherosclerosis. But most of the times patients are asymptomatic, and when they are symptomatic, they may present already either with aortic rupture and they come in, or impeding rupture. And their clinical signs would be back pain and lower back pain. So how do we define abdominal aortic aneurysms? Is when we see that the aorta measures over 3 centimeters, or when the size of the aorta increased in the aortic diameter 1.5 times more than the normal segment. We divide abdominal aortic aneurysm by shape into fusiforms, and that's usually a true aneurysms, and usually due to the atherosclerotic disease, or due they could be saccular. And this is a false aneurysms, and most of the times associated with infectious process or trauma. Patients with IV drug abuse, they develop mycotic aneurysms, and that's the way that looks. By location, we divide them aorta into suprarenal aneurysms that involve renal arteries and extends proximally, juxtarenal that involves our renal arteries and extends distally, or infrarenal, about 10 millimeter lower than the renal arteries. But if you follow the rule that if you see that AAA is over 2 centimeter below the SMA, most likely you're dealing with infrarenal abdominal aneurysm. Ultrasound is the best modality to evaluate or screen for AAA and do the surveillance for AAA with accuracy of 100%. And screening usually is offered to patients who are males over 65 years old and who has a history of smoking. And the whole point of screening is that to reduce mortality from AAA. There are special intervals between ultrasound surveillance were developed, and it's dependent on its size. So annually, you would screen somebody or do the surveillance who has aneurysm 3 to 4 centimeter. Every 6 months, if it's 4 to 4.5 centimeter aneurysms, 3 to 6 months, every 3 to 6 months, if it's an aneurysm of 4.5 to 5 centimeter. And then you're thinking about either again, doing the surveillance, or you send the patient for the elective surgery. Why we wanted to screen is because there is a high risk of rupture of AAAs, and it is known that the risk of rupture depends on growth rate and also the size of the aneurysm. So what is considered to be the significant growth? When the AAA measures greater, the significant growth is if it's growing greater than 1 centimeter in 12 months. And this is an important number to remember. And also risk of rupture is higher if the aneurysmal sac is large. For example, 5 to 7 centimeter aneurysms have up to 11% of risk rupture per year. Also, statistics depends on the gender, and it's known that females have a higher risk of rupture, and they rupture at the smaller size of the aneurysmal sac. So if a rupture occurs, there is approximately 60% mortality rate following the rupture. And this is one of the images that describes or shows abdominal aortic aneurysm with a complex fluid enveloping anterior abdominal aorta, and this is a hemorrhage from the rupture, and this is already post-operative CT that demonstrates the same retroperitoneal hemorrhage associated with the ruptured aneurysm. There are a few things that you can use for management, either open surgery or endovascular stent graft repair. The candidates are those who have a diameter of the abdominal aorta over 5.5 centimeter, or there is increase in size by 2.5 times of normal aortic diameter. So if the abdominal aortic aneurysm grow greater than 1 centimeter, this is also a candidate for treatment. And of course, those who present already with ruptured and symptomatic aneurysms. Multiple studies were done that confirmed that EVAR has a mortality and morbidity lower than the open surgery, especially those patients who have chronic renal disease or those who have a COPD. And there is fewer cardiac events in the perioperative patients in this population. So EVARs, the stent grafts, I just wanted to show you different types of the grafts. And what it does is that it excludes the aneurysmal sac from the system, the arterial system. What are the predictors of EVAR success? You wanted to have a really good anatomy, and vascular anatomy is #1 thing. So we're looking for neck anatomy, so it has to be a good long neck so that the stent graft can be placed with no issues, and it shouldn't be too tortuous. The aorta has to have a special angle in the neck, and also the neck shouldn't be flaring at the top, so otherwise it's going to have a high tendency of development of endoleaks, and if it's funnels downward, then it's really going to may cause migration of the stent after placement. So other things, we wanted to make sure that it's really good prosthesis is chosen by the size, and it's heavily operator dependent. There are a few things that we use for surveillance, either CTA or color Doppler, and what we wanted to do is to confirm the position of the device, also assess integrity of the device, and confirm the stability of the size of the aneurysmal sac. What we wanted to do is we wanted to exclude the endoleaks, and there is usually an annual follow-up and or every 6 months follow-up that is suggested. When we do an ultrasound for surveillance, we wanted to evaluate on a grayscale first. We're looking for position, location of the stent, and we're looking for device integrity, as well as we measure the aneurysmal sac. On the color Doppler, we're looking for the patency of the stent itself, of the limbs, and we're looking for any possible flow within the aneurysmal sac that will give us an idea that maybe there is an endoleak. So specific emphasis usually is made to the edges of the graft and within the aneurysmal sac. Multiple complications associated with EVAR Majority of them are endoleaks, and that's why we spend a lot of time on learning them. But there is also graft migration. There is partial complete lip occlusion, structural failures that can happen to it, pelvic or lower extremity or colonic ischemia due to other embolic events, or sometimes perigraft aneurysmal formation and access-related injuries. Stent graft migration affects approximately 3.6% of patients undergoing EVAR, and it's due to inadequate apposition of the stent graft onto the arterial wall. And management usually is endovascular open revision. So what we see here is on the CT, there is a mid-abdominal aortic aneurysm that is pretty big, involves the SMA, and we see that the stent on the coronal images is migrated downward, and it's really not covering the aneurysm. And the same thing you could see on the reconstructions. On ultrasound, again, we see that there is a flow within the SMA and some flow, we didn't detect it here, but the stent is not visualized in the expected location where the aneurysm is. Pelvic ischemia and lower extremity ischemia usually is due to other embolic event that throws the emboli into the distal circulation and causes, corresponding injuries. So in this example, we have somebody who just had endovascular stent graft repair, and on the same day later on complained of loss of arterial pulses in the right lower extremity. So we did a Doppler ultrasound of the right lower extremity, and that demonstrated no flow within the SFA, and as well as no spectral Doppler waveforms. So it was occluded SFA and needed anticoagulation. Colonic ischemia happens to up to 3% of cases, and mortality rate is really high. So because they develop a gangrene of the bowel, and they really go into sepsis, and it's really bad outcome. So it's important to notice this thing. So this patient had endovascular stent graft repair. Prior to procedure, the bowel loops look fine, and then post-procedural loops look thickened. And the same thing as on the CT. Pre-procedure, bowel loops look good, and then post-procedural bowel loops develop a thickening, and it's consistent with ischemia. So that patient had to go through surgery. Limb occlusion can also happen in patients with AVAR, and it happened in up to 5% of patients, and we divide it into the early occlusion or late occlusion. Early occlusion happens usually in the first few months, and thrombectomy, relining of stent graft with another stent graft, or anticoagulation or bypasses are the treatment of choice. So on this examination, we see that one of the limbs is occluded. There is no flow on color Doppler or spectral Doppler, and endovascular angiogram is performed that demonstrates no opacification of the left lower extremity system. Stenosis is another complication that may happen, and it may happen either to one limb or to both limbs, like in this case, and elevated peak systolic velocity as well as aliasing will be found on a color and spectral Doppler ultrasound. Noticing these things also is very important for patient management. A loss of device integrity could be seen with fractures, bending, or bulging of the graft. So when you see that the shape of the stent graft is not uniform and there is some bulging, like in this case, it also has to be mentioned, and the surveillance has to pay attention in the next follow-up visit. When the aneurysmal sac is growing, and it's a high possibility of rupture. So it's a very serious complication, and usually due to continuous enlargement of the aneurysmal sac results in rupture. And most common cause is endoleaks. So we're gonna try to evaluate the endoleaks and see how we can divide them. So type 1 endoleak usually is due to inadequate apposition between the stent graft and artery, either in the proximal portion of the stent graft, and that would be type 1A, or in the distal portion, it would be type 1B. They also have a type 1C that is due to inadequate seal of iliac occluded device. And when type 1A or B is detected, then it requires some repairs. And this is an example where we're looking at the transverse image color Doppler that demonstrates that at the most proximal portion of the stent, there is extravasation of the color into the aneurysmal sac, and we see on a spectral Doppler that there is an arterialized waveform seen within the aneurysmal sac. So on the CNA clip, again, you could see that the blood the color Doppler is filling the aneurysmal sac, and also the thrombus looks very irregular with lucencies and more higher density material within the aneurysmal sac, and lucent parts correspond to the active blood flow within the sac. Correlative CTA also shows the same contrast extravasation at the most proximal portion of the stent graft. And this is another patient on the sagittal view. You can also see it sometimes and can come from more anterior aspect of the stent and more posterior aspect. If it's a chimney procedure, then you look where the renal stents are. That's the places where usually endoleaks are happening. Again, we could see the flow. This is a patient with type 1B, where the endoleak is seen in the distal portion of the stent graft. Again, corresponding CTAs really confirm the findings on ultrasound. Type 2 endoleak is most common, occurs on up to 20 to 30% of patients, and it's the one that persists for up to 6 months in 10 to 15% of patients. So usually we don't do much about it in the beginning unless the aneurysmal sacs start to enlarge, and we just observe them. If it's anterior feeding vessel is noted, it's usually due to IMA artery that supplies the aneurysmal sac, and if you find the vessels that posteriorly feed in the vessel, the aneurysmal sac, most likely you're dealing with the lumbar arteries. And one of the examples is here. We have an aneurysmal sac that is on a color Doppler, demonstrates color flow within, and there is an arterialized waveforms to and fro within the aneurysmal sac, extending outside, and showing that this is from the feeding vessel. And the same is on the sagittal projection here. This is an aneurysmal sac, and we have a flow within it from the feeding vessel from the IMA. And here it is on the CTA, confirms the findings. And of course, we have a lumbar artery feeding. It would be a type 2B endoleak, and the vessel is coming usually posteriorly and fills in the aneurysmal sac posteriorly. So again, to and fro flow sometimes can be noticed just because it's a retrograde filling of the aneurysmal sac, and interventional images confirm the diagnosis. Type 3 endoleak occurs due to tear in the body of the graft or inadequate apposition of the graft with the native vessel or separation of the components. Usually, again, these patients need a relining the stent graft with a new stent graft components. So on the ultrasound examination, grayscale is really paramount. We could see that there is a there is a tear within the graft, like in this patient posteriorly on the sagittal projection. You can also see that there is overlapping of the structures, and there is an arterial waveform seen within the aneurysmal sac. So on a CNA clip, you could actually see how the the area of tear is moving with the blood flow. And this is another type 3 endoleak where we have a stent graft, and if you look in on these images, there is an irregularity of the wall, and that's the area where the blood escapes from the stent and fills in the aneurysmal sac. Again, the thrombus within the aneurysmal excluded portion is very irregular and different echogenicities due to presence of active flow within. And you could observe on a grayscale how it's pulsating as well, and CTA confirms the findings. And sometimes it could be really bizarre endoleaks, and it's really hard to find the source of them. And like this patient had really what looks like extremely big aneurysmal sac, and that is filled with lots of color, and on grayscale it's all moving, and it's really looked terrible. However, angiogram was performed, and they just couldn't find that much of a leak, and they thought that the lumbar arteries probably are filling it. Type 4 endoleak is usually caused by too many pores in the graft and occurs intraprocedurally, so we don't usually see this with ultrasound. And endoleak type 5 is due to the end detention. Again, no identifiable cause is seen, and it's diagnosis of exclusion. So one thing I wanted to just mention that sometimes infectious processes can also cause complications of EVARs, and it usually due to like undergoing infectious diseases in the abdomen, such as appendicitis or diverticulitis, or it could be due to aorta-enteric fistula, which most of the times we see on the CT as an air within the aneurysmal sac and the bowel that is adherent to the EVAR, and usually only patients with status post-EVAR develop the aorta-enteric fistulas. On ultrasound, it's much harder to observe it, only if you see like a bowel loop that may be not peristalsis and sort of adherent and not moving much, so you can suspect it if the patient is septic. Aneurysm formation just below the stent graft can also happen, and if it's diagnosed, it has to be mentioned in the report as well, because they can also go and grow and rupture. And the access arterial injury can also be found, or either like dissections or arterial thrombosis or pseudoaneurysm formation, like in this case. And we can detect the to and fro flow within the neck and yin-yang sun within the aneurysmal sac. So as a summary, I just wanted to say that Doppler ultrasound plays an important role in evaluation and surveillance of aortic pathologies, including AAA and post-AAA repair, and knowledge of anatomy, appropriate technique, and prompt recognition of complication is essential for diagnosis of EVAR complications. And ultrasound and CTA are complementary imaging modality that are great tools for surveillance of patients after EVAR. Thank you. And we're going to go.